Next up, we've got the amazing Lauren Sanders. She's an associate professor at St Vincent's Hospital in Melbourne, and she looks after adults with SMA, and she's going to take us through any updates, what she's been working on over the last couple of months, and we cannot wait to hear what she's got to say, and hopefully she'll update us about some stuff after the announcement on Friday for adults with Spinraza. So take it away, Lauren.
Thank you, Julie. And thank you to everybody for joining today. It's lovely to see some familiar names on the slides there as well. So I am in a recording studio this morning. Some of you will know that I wear a couple of different hats. I have my neuromuscular hat. I also have a stroke hat and a headache hat. And following my presentation today, I'm actually doing some webinar recordings for GPs about understanding stroke. So I am in a different location and there may be a little bit of background noise. So apologies in advance for that. All right, Julie, could I have the next slide, please? Which is just my disclosures to say that I have actually done a little bit of paid advisory work with Biogen and Roche, and that's probably the only bit that's relevant to today. Next slide, thanks. So I would like to start by acknowledging that I'm presenting today on the lands of the Wurundjeri people of the Kulin Nation, and they are the traditional custodians of this land, and I do pay my respects to their elders, past, present and emerging, and I acknowledge any Indigenous people or First Nations people on the line with us today. So what I'm going to go through is a couple of things that we've been working on over the last few years to few months, and then of course, the exciting news on Friday about Spinraza now being accessible for adults with SMA. And if any of you saw my Instagram post, I can't think how many times I used the word excited, but I just couldn't think of another word. And it's just exciting to think that now we actually have a treatment that does make a difference, and it's going to be available for adults with spinal muscular atrophy. And in the lead up to this, we did a lot of work with the community and partnerships with industry clinicians and adults living with SMA to try to understand and make sure that we were really addressing the needs that needed to be addressed. And as part of that, we ran some focus groups, and I'll be presenting some of the findings from that today. So I'm going to go through what adults living with SMA told us about what they want from a neurologist, what they thought about the assessments that are out there for SMA, which have really been adapted from the paediatric landscape, what they expected and what they hoped for from treatment. I'll talk a little bit about my experience thus far with starting adults onto nusinersen, and I now have 12 adults who are undergoing treatment at St Vincent's in Melbourne. And then I'd like to present some of the proposed statements around a consensus statement, which has been co-designed based on the information that people with SMA have told us in the focus groups. And what we're trying to achieve is a co-designed management guideline for adults with SMA so that clinicians are really treating to standard and that we're minimising that inequity of access to specialist care around Australia. Next slide, thanks. So we put together some focus groups in December last year. There was a call out for adults living with SMA via various social media postings and through the SMA Australia newsletter and mail outs in that way. And we put the protocol for the way that we were going to run the focus groups through our ethics committee at St Vincent's Hospital. And there are a couple of reasons why we did it in that way. We knew that the results of these focus groups were going to be used to contribute to the consumer comments submission to the PBAC. And we also knew that these results were going to inform a co-design of a consensus statement. And we felt that putting the protocol and the process through an ethics committee gave it an additional layer of integrity. It also meant that we had an independent review of how we were going to be asking people about what could be really quite sensitive discussion topics around their health, their hopes, and their expectations. Importantly, this was independent of any industry funding. And I think that was also important going into PBAC consumer submission, that we didn't actually have any biases from there being industry sponsorship here. And the way that we ran things were that once there'd been an expression of interest, I contacted people to discuss how the focus groups would run. There was a pre-session survey that introduced a number of the themes that would be covered in the focus groups. There was quite a bit of pre-reading around the assessments that are done for or validated for adults with SMA. There was also the results of an advisory board that had been run with neurologists and our thoughts around what should be going into a consensus statement. And then we followed up with a 2-hour focus group session via Zoom. And we ended up having 28 adults with spinal muscular atrophy contribute. We had every state and territory except for ACT represented. We had a really wide range of ages from age 28 through to 65. And we also had a really broad representation of different disease severity in terms of type 1, type 2, type 3, and also in terms of the newer terminology that Robin alluded to today with the non-sitter, sitter, and walker classifications. I was the facilitator for all of the groups, and for a couple of the groups, we also had Neurologist Associate Professor Katrina Reardon, who's got a lot of expertise in looking after adults with SMA as well. So we covered 4 themes in these groups. We covered the expectations and what you really needed from a neurologist, because we really recognise that this often is malaligned with what I think we need to be doing as the neurologist and what the person with SMA needs from me as a neurologist. We went through the physical assessments, the patient-reported outcome measures, and I'll talk to that a little bit, as well as what we thought should be criteria for access to treatment, because that was really important to put into the consumer comments submission. So we ended up having 9 different groups with 17 hours of transcripts. And I would just say a huge shout out to SMA Australia for providing some funding for us to get the transcripts professionally transcribed, because I really just didn't have time to go through 17 hours of recording and type it all up. But it's really important when we do focus groups like this that we actually have verbatim records of what people said, because so much rich data is in what the spoken word has contributed. Next slide, thanks. The first theme that we spoke about was the role of the neurologist. And some of you will have heard me say so far that it's actually been a really humbling experience to hear in so many ways how my profession has actually failed people living with spinal muscular atrophy, but also to see how far we still have to come. But in the same way, hearing some of the really good stories and where we've got it right is really important for us to understand how to drive things forward. And there were a lot of different experiences. Some people were really engaged with their neurologist. Some people hadn't seen a neurologist for decades. And what became really apparent was there is a significant inequity across Australia of access to specialist care. And this really impacted on people's experiences with access to treatments and access to therapy, and also to their understanding of their own individual SMA. As Robin mentioned in her talk, adults have very limited access to multidisciplinary clinics. Most people had heard of the concept or may have experienced it in paediatrics, but very few people had access to that as an adult. The majority of people felt that this would be beneficial, and by a multidisciplinary clinic, I mean when you're attending your appointment and you see your physiotherapist and you might see the respiratory physician and maybe your bone specialist all in one appointment. And so there was a lot of favour for having options for that model, but the recognition that one size does not fit all, and that some people actually prefer to split up those assessments across different appointments. The fact that seeing it all in one day can be quite fatiguing, particularly if you have a severer expression of your SMA, that all of that in one day may just be too much, and that's okay. So there needs to be some flexibility in the system. What also became apparent was that there was a really poor attention and at times and often neglect of attending to people's mental well-being. And it was interesting for me as a neurologist to understand how many people reported anxiety around their SMA, and the anxiety around when would things change, how long would they be able to keep doing the things that they could do right now. And so I think this is a really neglected area that we need to step up more towards. And what people also told us is that there were some really key elements to what a good neurologist should be providing and what our role really needs to take the shape of. And this included, most importantly, person-centered care. And there's this lovely quote here, and I have provided a few quotes throughout the presentation. I like them to understand about my life in all of its aspects rather than just my medical condition. And people gave examples of the differences between feeling like they had really been listened to as an individual and treated as an individual versus experiences where they'd just been seen as the next patient with SMA. People also wanted an increase in education for the neurologist to be educating them about their disease, so they didn't necessarily have to be seeking it out on their own, but also to be educating their other clinicians, their general practitioners, their other treating team members. And in situations where people didn't have access to tertiary centres, but the neurologist would take on that role of making sure that expertise was available and provided. Obviously, access to treatments. I'm actually surprised there are a number of neurologists who, when I've spoken to them recently, said, "What's nusinersen?" And I'm thinking, oh my goodness, so there needed to be an increase in our understanding of access to treatment so that we were continually communicating that to our patients and providing them with an understanding of what might be coming next. It was important for us to be involved in care coordination. So understanding that there needed to be a respiratory physician, maybe a bone health physician, and the physio and the OT and the speech therapist and the nutritionist, and all of these people involved in the recognition that the public health system really sucks and it's really not designed as a user-friendly interaction, and that part of our role is actually to help people navigate this system. And then what's becoming an evolving role or a newer role really is that role of advocacy. And a big shout out to Micheline Lee, who I know is on the line today, for really driving me and inspiring me to take on a more significant role in advocacy. Certainly that has changed my practice, and I'm really grateful for that. And I think we can learn so much when we take the time to listen to what our patients are telling us. And so there's this great quote here as well. I think part of neurology as well is advocating some of the other specialists and treatment approaches, but also establishing a really good medical team around the person as well. So lots of different things for us to take on board as neurologists. And I will be presenting these data back to neurologists at the Australia and New Zealand Association of Neurologists conference is in May, which is a great opportunity for us to get the voices of adults with SMA out to the treating neurologists. Next slide, thanks. So we spoke a lot about motor assessments in the focus groups as well. And the three key ones that are used quite commonly at the moment for adults are the 6-minute walk test. So that's how far can you walk in 6 minutes if you're able to walk. The revised upper limb module, which mostly focuses on functions around arm, and then the Hammersmith functional motor scale, which is developed for pediatrics, and it involves a lot of things like rolling over and crawling, which really don't translate that well into the adult setting. So with regard to the 6-minute walk test, we didn't have a lot of people who were walking in our focus groups, but only 15% of people had actually experienced a 6-minute walk test. Just over a third had experienced the revised upper limb module. And if you think back to the data that Robin showed earlier this morning, certainly that is becoming the more common assessment that we're seeing for adults. And around a quarter had the Hammersmith score. And so we spoke about whether these scores really represented what was important to adults. And the general feeling was that they're not quite right. And again, there is no one size fits all. The majority of people in the focus groups agreed that SMA physical change should actually be formally monitored. And this is a shift away from the traditional approach that we've had in neurology, where we've kind of just maybe said, oh, wave your arms at me, or what can't you do now that you could do 12 months ago? And we haven't paid a lot of attention to a formal assessment because we've anticipated a decline and nothing we could do about it. But really, we should be paying attention to what things are changing and asking people and measuring what's actually changing. When we asked people about what they thought was an appropriate interval, obviously this needs to be individualised, but the majority of people thought that a 6 to 12 month frequency was appropriate and as needed in between. I think the 12-month interval is probably the maximum I'd like people to go. And that's mostly because there's such a change in the landscape about evolving therapies and where we should be headed, and wanting to make sure that we don't miss things, miss opportunities to introduce new therapies. Interestingly, in the pre-survey, most people felt that the neurologist should be doing the motor assessments, but the Hammersmith can take up to 30 minutes. And most of you will know that the neurologist doesn't have 30 minutes in their consultation to be doing just the physical examination. And so when we spoke through that, there was an agreement that perhaps these are better placed with the physiotherapists and potentially the physios funded through the NDIS, as they will have more regular interaction with that individual. There certainly were a lot of limitations. It's very difficult to jump between categories and increase or decrease the score. And so there was this comment that the worst thing is if the small improvements are totally ignored just because the tests don't cover them, but people may actually be experiencing a significant improvement on treatment, or similarly a significant decline that's not picked up by a test, but that needs to be addressed because it's made a functional impact for that individual. There was also quite a bit of discussion about the role of wheelchairs and people spending their day in their wheelchair and therefore needing to be assessed in their power chair. And so one person said, I don't see the point of them trying to get me out of my chair to measure how I roll when I know myself I can't roll, I can't sit independently. So some really powerful comments. Next slide, thanks. The next thing that we spoke about was patient-reported outcomes. And this has had a big shift in medicine in general over the last 5 years or so, where we're really focusing not just on the physical things that we can measure, but what people are telling us are important to them. And so I think this is a great quote that often the person with SMA can provide better feedback than any assessment or scoring tool. So really highlighting the need for us to listen. So only 16% of people had completed a validated patient-reported outcome measure. So there are a couple out there that have a list of questions about what people can do on their day-to-day activities, and then detecting how significantly certain activities may or may not be impacted on by the SMA. There were varying opinions about the capacity of the patient-reported outcomes to reflect meaningful change. A couple of scores were better than others, but recognising it didn't really detect everything that may be important to an individual. Where the groups mostly felt that these patient-reported outcome measures had benefit was in initiating conversation, and that perhaps there's a role to complete these questionnaires before coming to a consultation to identify key things that may not be brought up in the consultation otherwise. Limitations of the patient-reported outcomes were certainly, again, around mental well-being, about community engagement and the things that are meaningful to people in that way. Fatigue is a big issue for a lot of people and poorly addressed and poorly recognised. And those small but meaningful changes. So one person said, if I see an improvement with the length of time that I can write, then that would be an improvement to me, and it doesn't really categorise that. So lots of areas for consideration there, and also recognising how much we need to individualise our assessments, our approaches and our treatment strategies. Next slide, thanks. And what about treatment expectations? So this was really important to understand because this really did inform a lot of what we put into the consumer comments submission to the PBAC. And so overall, there was a general consensus that effectiveness would be stabilisation or a slowing of decline. And I think it surprised me how much emphasis people placed on that rather than an improvement. Obviously, an improvement would be incredible in a disease that is expected to decline, but people really felt that anything that stabilised or slowed that decline would also be effective. And that was really important in the recommendation made by the PBAC, was their understanding of what effectiveness meant to the people living with the condition. Again, there was concern that being unable to detect a clinically meaningful change may then influence the way that people perceived a treatment effectiveness, and that things like endurance or what may be small movements like movement of a thumb or a finger were actually really clinically meaningful, and that they need to be considered effective in terms of treatment, and a big focus on treatment to maintain independence. So one person said to me, I think stopping progression is just, I think, the main thing. Anything else is a bonus. And then I really liked this quote, and I actually put this quote in the consumer comments. Things that are like being able to tuck a blanket on at night, little things that other people can't do for you that would be really gross. I think that's really powerful. Next slide. So in the last couple of minutes, what about my experience so far? So I now have 12 adults being treated with nusinersen at St Vincent's Hospital, and 11 of those patients were started under the Biogen Free Access program. So we had a little bit of logistical challenges in the beginning, and that was mostly due to COVID and it being considered an elective procedure, which made it a little bit more challenging to convince people around the administrative side of things that we needed to get things going, but we did. The pictures that you can see there, up at the top, there's a CT scanner, and next to that is a CT scan. And that white line is actually a needle going into that person's spine. Down the bottom is a fluoroscopy screen, and next to that is a picture of a needle going into a spine in the way that we would visualize it under fluoroscopy. And the biggest challenges that we've faced was around spinal anatomy. And there was sort of no in between. People either had amazing spines, like the one on the bottom, or super complex spines, like the one at the top, where there was a lot of hardware from previous surgeries or there'd been spinal fusion. So that picture at the top, that person actually only has a couple of millimeters at one level on one side where we are able to get access. So far, we haven't failed to get access, but it can be quite challenging if there's been spinal fusion and no access into the intrathecal space. The most common side effect or complication has been post-lumbar puncture headache, but this is a really common finding after a lumbar puncture for any reason. I don't think it's related to the nusinersen, and I think it's related to the procedure. We're yet to be able to predict who's going to be more likely to have a headache after their procedure. The only thing I've noticed so far is it tends to be people who are more mobile or more ambulant who are experiencing the headaches. Hospital delays have been a big issue. We're yet to have one case that's gone exactly at the start time that we've planned, and that's because emergency cases come in or clinicians get caught up, and that's just unfortunately the nature of the public hospital. But most people need to block off at least half a day and then have a bit of a rest in the afternoon or take the next day off from work. And what about the clinical response? That's what everybody's really most interested in. Most people have felt something even early on. We don't expect change until maybe 12 to 14 months if you look at the clinical data. But a lot of people have said to me, I just feel a little bit more stable, or I feel a little bit more energy. I've had one person who is now able to help out with meal prep at the end of the day, whereas previously didn't have the endurance for that. I've had one person who's gone back to being able to put Lego blocks together when they'd put their Lego away 2 years ago because they could no longer put the blocks together. I've got one person who was so excited because they, without thinking, bent over and picked a T-shirt up off the floor, which they hadn't been able to do for ages. One person in the focus group said, I can stand longer. I'm walking down my hallway, which I haven't done on my own unassisted for the last 12 months. And then another person said little things like standing my elbow up, propping it up, and being able to hold it there for longer unsupported, going from like 20 seconds to now 40 seconds. And I've had one person also who's recovered enough anti-gravity movement in their thumb that they can now put their chair from reclined to sitting from a reclined position, whereas previously they had to ask a carer to do that. So I'm really looking forward to seeing if these changes are going to be sustained and whether we get further improvement. Next slide, thanks. So the last couple of slides are what I will be formally sending around, hopefully in the next few weeks to a month, around a draft of the consensus statement. It'll have more detail, and this is what I'll be presenting to neurologists for feedback at ANZAN. So these are a group of statements that we are hoping to put into a document that will be called a consensus statement. And importantly, this is co-designed by neurologists and by people living with SMA, because this has come out of the focus groups. So with relation to diagnosis, the consensus statement is likely to say that all adults should be offered the option for genetic confirmation. With assessments, neurological review should occur every 6 to 12 months, that formal assessments, physical assessments relevant to the individual SMA severity should be undertaken every 6 to 12 months, that patient-reported outcomes, either formal or informal, should be reviewed at each consultation, that respiratory function should be monitored on a regular basis, and that bone health should be monitored on a regular basis. And there may be a little bit of change to the wording around this, but these are the general concepts. Next slide, thanks. I think it's really important, welcome feedback, that we actually have a separate statement around mental and emotional wellbeing. And again, this wording may change, but attention to mental and emotional wellbeing should be included in each clinical review. It seems obvious, but it's not happening, and so I think we need to call it out. Also, a statement that advanced care planning should be discussed. We're not making specifications around that, but again, including the concept so that it's there to be individualised. With regard to treatment, the first important statement is that goals of treatment should be individualised, and that treatment with intrathecal nusinertion should be considered in eligible adults, meaning that the discussion should be had, it should be offered, but you don't have to have it if you don't want it. Access to new treatments should be monitored, and that physiotherapy should occur on a regular basis if we're going to make the most of treatment opportunities. And if people aren't having treatment, then physiotherapy, actually similar to what we just heard about in the paediatric landscape, really can have an impact. And certainly those intensive versus regular sessions can be just as helpful for adults as it can be for children. And next slide, which is my last slide. And this is the statements that we're thinking of including around treatment effectiveness. That treatment effectiveness should be determined using information from a combination of the validated physical assessments, the patient-reported outcomes, and the consultation between the adult living with SMA and the neuromuscular specialist. That effectiveness can be defined as improvement, stabilisation, or minimal decline in symptom over 2 years. And that was really important for the consumer comments submission. And that's a sustained or rapid decline in objective measures of SMA should prompt a formal discussion between the adult living with SMA and the neuromuscular specialist to consider stopping treatment, because sometimes those conversations are actually difficult to initiate. And sometimes people actually want to say, I don't want this anymore, and they don't know how to bring it up. So thank you for the opportunity to engage with the SMA community to gather this information. This is your lived experience, and it's been an absolute honour and a privilege to be part of hearing these stories, and thank you for trusting me with this information to present back to you today.
Thank you so much, Lauren. That was a fantastic talk. We're going to open the floor to questions. We're unmuting everyone, so feel free to put your hand up and we'll get you to ask a question or write your question in the chat box. I'll start with a question. When you were doing the focus groups, what was your most memorable moment? What made you smile the most?
Oh, wow, that's a really tough question. What made me actually smile the most was actually the generosity of patients or people living with SMA, not just to contribute for themselves, but for the bigger picture. And I came away from that just so inspired. After the first focus group, I think I spoke to you about it, Julie, because I was just so overwhelmed with hearing people's stories. I think that was the biggest thing for me.
It's fantastic when, you sort of bring someone into your world, you hear what they're about, and, their story can help that bigger picture. That's definitely one thing that's been inspiring for me over the years, for sure. We've got a question from Micheline. If you'd like to unmute yourself and ask, go ahead.
Hi, Micheline.
Hi, Lauren. Thank you so much. I feel you've given us a voice and expressed so clearly the experience of living with SMA. And I know from speaking with the others who were involved in the focus groups that we were very moved to be listened to as you listened to us, and to have our words represented with such empathy. And The report is a really powerful resource that has played a major role in the Spinraza approval, we feel, and it can continue to use to advocate for best practice treatment. So thank you very much.
Oh, thank you, Micheline, because as I said, you kickstarted me into this, and I'll be forever grateful to you for really changing my practice.
Perfect. So we have another question from Ellie Robinson. Please go ahead, unmute yourself, Ellie.
Hi, Ellie.
Thanks.
Nice to see you.
Oh, hello. Good, thank you. Yeah, how are you, Lauren?
I'm good.
That's good, thanks. I have a question about a formal document that could be written by neurologists that are experienced with SMA that could be presented to NDIS. And I know everyone is totally different, or everyone with SMA, even the same types, can vary. But is there more like a general document that we can produce or show NDIS? The reason I'm asking is that every time I need a piece of equipment, or even to go from one plan to another, I have to employ all these professionals to again state that I have this disability, it is continuing, it's actually deteriorating. And I feel like I'm constantly having to prove my disability. So is there something that we can say, look, this is SMA, this is what I have been formally diagnosed with, and this is the outcome of having this disability?
Yeah, look, Ellie, I think this is a really important next step. We've gathered so much information now. We plan to publish the consensus statement, and I think that's going to be a really powerful document. I think that's the next step, and certainly we'll be able to guide the NDIS to that document. And then perhaps I think it's a great idea. Maybe the next step is that we engage with NDIS and say, look, there are so many adults with SMA who are coming through NDIS. We can make your life easier if we help you with this document, and you're going to make our lives easier as well. And maybe we then leverage off what we're writing with the consumer comments. We've got that document now, what we're writing for the consensus statement. Maybe that's the next step, that we engage with them and say, we can make your life easier by writing this for you. It's a great idea.
If they want to make their lives easier, it doesn't sound like it though.
Oh, well. I think there's always hope. We just keep squeaky wheel. Yeah.
Thank you.
Lauren, do you do much engagement with the NDIS, or is it mainly patients?
Other than cursing them, there's a lot of swear words in my head go the NDIS way. It's the most frustrating, time-consuming part of my clinic, is getting these letters back that go, why does this person have this? I'm like, I've told you they've got a degenerative condition. There's no cure. Read my letters, read my previous report. Don't waste my time. I mean, I had a person with FSHD, facioscapular hemodystrophy. Part of that condition is foot drop. They asked me to write back and explain why the person had a foot drop. I mean, I know they're not clinicians, but surely my many years of study in this field counts for something.
For sure. Has anyone else got any questions before we bid Lauren a farewell? I just want to say it's been phenomenal working with you. I cannot thank you enough for your openness and your willingness to share your expertise and your information. It's been a joy and an honor, and thank you so much. It's been fantastic. So
thank you.